this first of the Department of Medicine Seminar Series 2020 after what has been, I think, the non-word of this year is probably unprecedented circumstances. I'm really pleased to have three fantastic speakers, and kind of the topic of today's seminar is, hey guys, what were you up to the last 8 weeks? What did you do? And I think they have some fantastic stories to tell. I would also like to thank the Department of Medicine, first of all, my own department, for really being proactive during these weeks of uncertainty and weeks of we didn't really know what to do. There was so much email traffic, there were so many Zoom meetings, there were so many happenings during those weeks that it was really at points difficult to keep your head above water. But I think you guys have done fantastically well from the department. You kept working, you kept looking after our students, even if we didn't really know whether the students were there or not. And of course, having James and Jack talking here today, as well as Susan, you kept looking after our patients, which was absolutely amazing and appreciated. So while this is hopefully a thing of the past now, and we have a little bit more normality, there are still emails flying, and I still need to ask you for a little bit more patience in all of this and follow the rules and the guidelines that are coming left, right, and center from all various organizations that think they have something to say about that. The students loved the online teaching. I think the students really liked the fact that they were their own masters. We didn't ask them to start at 8 o'clock in the morning. We didn't tell them when to have their lunch break, all of that. So that was good. And I think the feedback that we've got from our students was absolutely amazing and fantastic. So thanks to Steve Johnson and to Liz Latta as the teaching committee chair people, and thanks to all the other conveners, Jerry Wilkins and Rob Walker, for their work. But what I thought would be a fantastic first seminar is just to see these people at the cold front, to see these people who actually have done all the work, to tell us a little bit what it was working behind the scenes, and of course for some of you guys working in front of the scene. So Susan sits, I think, up in Walkery with her office, and Susan is the medical officer of health. So what I've been told is that Susan was basically in charge of our response to this threat from the outside. And Susan, why don't you just kick it off and tell us what you were up to the last 5 weeks or so?
Okay, thanks a lot, Michael. Can you hear me okay? Yeah.
I can, yep.
Great. Okay, thanks. So, yeah, I'm the clinical director of our public health unit, and our offices, like you said, are based up here at Walkery Hospital. But actually, since the start of the year, since the last week of January, we set up in the DHB, the Emerging Infectious Diseases Coordinating Committee, as we could see the threat of COVID coming towards us. We got our first case in the south on, I think it was Saturday, the 13th of March. We'd been preparing all that time, not only as a public health unit, but across the whole DHB. So this has been a huge team effort. So I'm going to start talking today, giving you a little bit of background or just an overview really of the New Zealand and then the southern situation. Then going to hand it over to James to talk about diagnostics, which has been a key part of our response, and hopefully the future for vaccines. And then Jack is going to be talking about the preparations that went on in the hospital for preparing for a COVID-19 ward. And then hopefully there'll be some time for questions at the end. So I'm sure many of you are following the Johns Hopkins University data dashboard, and this is probably one of the first things that I look at every morning. You will have maybe seen that yesterday we hit a global total of just over 5 million, with 329,000, well, nearly 330,000 deaths. Many people are saying that the death rate is underestimated by quite a large degree. In some countries, they haven't counted all the deaths, particularly those that were in aged residential care facilities for various reasons, perhaps data issues. So please look at that 330,000 and know that it will be an underestimate. The same actually goes for the total of confirmed cases. We know that in some countries, the testing has been very restricted. So although it's 5 million, you could, I don't know, probably double that to get the true number. So in New Zealand, our situation, unless I've missed that there's a new case today, our total is 1,503 cases. Most of those were confirmed cases, so that means somebody went and had the test and tested positive by the PCR nasopharyngeal test, and then 350 were probable cases. Similarly, in New Zealand, the case definition has changed multiple times, and it was only latterly that probable cases were part of the case definition. And even then, there was a case definition, and then a few days later, they changed it. So there were probably a lot more cases than this, even in New Zealand, but this is our best estimate, or the best record of data that we've got. Most of the people, our cases have fully recovered. Very sadly, we've had 21 deaths across New Zealand. More than half of those have been in people that were in aged residential care facilities. And that is one of our high-risk areas that moving forward, we need to take the lessons learned and be prepared for that kind of eventuality. There are still around 30 active cases, and currently, well, as of yesterday, there was one case that was still hospitalised. So in New Zealand, the basic plan of approaching this outbreak or pending outbreak was to first of all plan for it, then to try and keep it out through border control, preparation, communication, surveillance, self-isolation, stamp it out, so picking up cases as early as possible, contact tracing and isolation, and really trying to contain the outbreak to a small number of people, manage it as in delaying that increase through some of those control, surveillance, self-isolation, but also infection control has really come to the forefront as a very important mechanism for managing outbreaks, closure of institutions. And we had this, I wrote this slide actually back in March, and we had bracing the health system and the public. Really, thankfully, we haven't overwhelmed our hospital part of our health system. So that's been a great team effort by everybody, and then recover from it. So right now, we're still actually in all those processes. So yes, we're looking at recovery, but at the same time, we're also planning for if we should get a second wave. My current feeling is that at the moment, our risk is very low. We don't have any evidence of community or ongoing transmission in New Zealand. However, as soon as we open our borders again, even to Australia, but then particularly to the rest of the world, we need to be prepared for a second wave. So up and down the country, public health units, and I know hospitals as well, are looking at planning, and we've been asked specifically by the Ministry of Health to be able to have a surge response that we're needing to submit to them, relook at all our processes of what has happened this time and plan for it if there should be another time. So this is the epi curve for all of New Zealand. You can see we had our first cases back in mid-February. We had 1 or 2 cases. We had a very slow start, and I think we thought, you know, maybe we would get away with things. The TR stands for travel restriction. So at this point, early on, alert level 1, we had travel restrictions from China. Then it was extended to Iran, then northern Italy and Korea. Then suddenly we started seeing more and more cases. And at this point, I don't know if you'll remember, but that's when there started to be a huge surge of cases in, first of all, Italy, and then other countries in Europe and in the UK. But unfortunately, our travel restriction was extended to northern Italy, and then I don't believe fast enough to these other countries that were emerging hotspots. Having said that, it did all happen pretty quickly. At this point, we asked all travellers to isolate, But to be honest, by that time, especially for the south, where we had many visitors coming into Queenstown, so the southern cases are here in pink, the horse had a little bit bolted. Nevertheless, asking all travellers to isolate, then the borders were closed, and then here is lockdown level, alert level 4, where everybody was asked to isolate. And it was really that level 4 lockdown that I believe enabled us to come down this other side of the curve. When we look at it by DHB, what happened across our country, Waikato, Auckland and counties had large numbers, Waikato, Canterbury, and here is Southern. So we had a very sharp peak, and it was actually over a 2-week period that we got most of our cases, and we had to do a very rapid surge response in how we were managing things and basically change things up as we were going along. Thankfully, we did have a lot of people trained to do contact tracing. We had done that process quite early on, and we actually had 135 people ready and waiting and trained should we have needed them. In the end, we used 100 people for our contact tracing. What we began to find though, as our case numbers increased, was that we needed more nurse case managers and case monitors to deal with our cases, who were by and large being managed at home. In the south, we had 7 people hospitalised out of our 216 cases. Some of them were just in overnight or for a couple of nights, more for observation. Some of them, as you know, were in much longer, and we had one in ICU that was there for a long time who sadly passed away. We had 2 deaths, one from ICU in Dunedin and one who was at home in Invercargill. So this is what the epicurve looks like just for our southern outbreak. First case in New Zealand was the 28th. This is the onset date. So our first case was reported on the 13th of March, but the onset date was the 11th. And then, so this is by onset date of illness rather than reporting date, which was the previous slide. The brownie red bars represent our probable cases. Early on in the outbreak, these probable cases were by and large children whose families, the parents had gone for a nasopharyngeal swab, found it an eye-watering experience, and so declined swabbing on behalf of their children. However, they fitted the case definition and they were in close contact with someone. Later on, the case definition widened for probable cases, and so we have a few more. And in fact, our last several cases were all probable cases. This is what the cumulative graph looks like. So the blue bars are our cases, and then the yellow bars are when our cases started recovering. So a steep increase to our maximum 216, which we reached by about the 17th of April. And then no further cases, and gradually everybody recovering. And I'll talk a little bit more about that in a minute. This is just a heat map showing where we had the greatest number of cases, and you probably have seen these graphs already. So Queenstown Lakes was certainly our biggest hotspot, followed by Dunedin City, then Invercargill, and we had a smattering of other cases, Central Otago, and in the broader Southland district, other than Invercargill City. ESR have done some analysis looking at symptoms and symptom combinations in New Zealand, and this is an interesting point because right at the start of the outbreak, the case definition was quite restrictive. It was you had to have fever of 38 or more and a cough before you were allowed to be swabbed. Pretty early on, we realized that that case definition was going to miss a whole lot of people, and especially when we had people that were isolated because they were close contacts of someone else, we were picking up them very early in their illness, and we early on were seeing that actually coryzal symptoms, runny nose, sore throat were quite big features. So the case definition sometimes took a bit of time before it was changed, but we in the South did work very, very closely with primary care, with the community-based assessment centres and GP practices to actually widen that case definition. There were a couple of parts to the case definition. You had to have the symptoms, and then initially it was just if you had travelled in a hotspot area, so China, then Northern Italy, then Italy, eventually to all countries. And then eventually it was basically anyone who was symptomatic. Because Queenstown was one of our hotspots, what we found earlier, perhaps in other places around New Zealand, that a lot of our cases had not travelled themselves, but they'd been in close contact with other travellers, with tourists. They were running the tour buses, or they were running the jet shot over river jet boats or something like that. So about a week to 10 days ahead of the national case definition change, we changed it in the South. So if you had had contact with a traveller and you had these symptoms, then you could be swabbed. And if you look at these symptoms, the greatest proportion actually have cough, and then the next combination is cough and fever. And then the next most common one is cough, headache, sore throat, and fever. And quite early on as well, other countries were saying fever may or may not be a feature of the presenting symptom. In fact, a lot of people didn't develop fever until some days later. So that also got changed in our New Zealand case definition. But because it was an emerging illness, we were all learning on the job and trying to figure out this interesting new disease as we went along. Okay, this is my last slide, and I just wanted to show it because again, early on, the evidence that we had coming out of World Health Organization and the early evidence from China suggested that most people would recover by about 14 days. As our outbreak progressed in the South, we recognized that a lot of our cases were not recovering within 14 days. So we've done some preliminary analysis and found that our median time to recovery is 18 days, and only 5% had recovered by 10 days, which is actually what the UK definition is at the moment, and around 95% by 34 days. So this is separated out by age, and you can see that the younger you are, the faster you recover, which may or may not be surprising, except that, remember, most of our cases were mild enough to be managed at home. So we're not talking about people who are hospitalized who we know would have a more prolonged course. These are by and large people who were managed at home, so we're on the mild end of the spectrum. We're doing some work with some other public health units to write up a case series on our cases that have had a really prolonged course. We're waiting for some other publications. There's some interesting blogs that have been written by infectious disease physicians and professors of their own personal experience. And it just reflects what we're seeing, where this can be a relapsing illness. People can recover, and then a week or so later, they get a recurrence of symptoms. And a lot of it is sort of muscle aches and fatigue, some people getting a recurrence of sore throat. So as I said, we're learning as we go. Okay, I'm going to hand over to James now.
Thank you, Susan. Fantastic. Now, are you going to stay online for the entire seminar so we can ask you questions later on?
Yes. Yeah.
Fantastic. Thank you so much. So, James Ussher, who some of you might or might not know, works at the Southern Community Laboratories, but he's also a member of the University of Otago in the Department of Microbiology and Immunology. And it must have been really exciting for you, James, to be on that front, because obviously as clinician, all we got from Southern Community Labs was, oh, we can't do this test anymore, we can't do that test anymore because we're now busy with COVID testing. But there wasn't really, at least I didn't see really an explanation of what had to happen in Southern Community Labs to kind of go through that tsunami of testing. All we had was Jacinda Ardern and Ashley Bloomfield telling us that our number of tests are going up and up and up, and we can test basically everybody we want to test at some point. So thank you so much for agreeing to give us an insight into what actually happened behind the scenes in Southern Community Labs.
Sure. Okay, look, thanks for the introduction, Michael. Can you hear me all right?
Yep, I think we can hear you right, yep.
Okay, so the year didn't quite start as expected. I was on holiday in Stewart Island and in mid-January and came back from holiday to see that we were experiencing the start of the outbreak of SARS-CoV-2, or the novel coronavirus Wuhan, as it was originally called. And had conversations early on in the piece where transmission was still fairly limited, mainly in China, but with Prof. Miguel Quinones Matau and his team at the University of Otago, and we decided that this looked like it was fairly serious, and that there was a significant risk this would spread, and we looked to set up an assay in-house. So the people who worked on this were Jenny Grant, who's the head of molecular pathology at Southern Community Labs, and Roderick Harflip and Blair Lawley, who are postdoctoral fellows with Miguel. So this was challenging to set up. We took a published assay from the Drosten group from Germany. They described 3 different assays, one targeting the RNA-dependent RNA polymerase, down here, one targeting the E gene and one targeting the N gene. And we elected to set up the RDRP and the E gene. As it turned out, while they both fuse a synthetic target, they're both equally sensitive. In clinical practice, the RDRP gene is about over 1,000-fold less sensitive than the E gene, so we rapidly dropped that. And we looked to set it up on this instrument that doesn't have a panther on it, but it's called the Panther. So it's a random access machine, so it does everything. You load the sample on, it does the RNA extraction, and that does the RNA extraction, and then does the reverse transcriptase and reverse transcription and polymerase chain reaction to detect the viral genome. The issue with this is that it's great once you've got an assay set up, a commercial assay, but setting one up, a lab-developed test, it's not straightforward, and as a black box, there's a lot behind the scenes. And the main issue we had was that we didn't have the virus, so we didn't have a positive control to set up the assay. So this is where we worked in with Miguel's group, and he designed some plasmids that were able to, we could translate a T7 RNA polymerase promoter, and we could transcribe RNA positive control template off that, and then we could use that to try and validate the assay. We also managed to obtain some viral RNA, a cDNA copy of the viral RNA from the Victorian Infectious Disease Reference Laboratory in Melbourne. So they kindly sent that to us as well. So it took a number of weeks to set this up. It wasn't a straightforward process, and Jenny and Blair and Rodri all worked really hard, and it was a great example of a fantastic collaboration between SCL and the university. And we got it up just in time. Our go-live date was Friday the 13th of March, and the first diagnosed case in Southern District Health Board was Friday the 13th of March on our assay. So we felt like we had, things had fallen together nicely, because we expected there to be a whole lot of testing after that. And prior to that, we were restricted to we could send samples off to Canterbury Health Labs, and there was while they did provide us with fantastic service, there were delays in transport and etc. So this is just looking at the number of tests that we have done over from when we started back on the 13th of March through to, I think it was yesterday I made this graph, and the top of the graph is 1,000 tests. So we started going from doing a few tests a day, and I just point out that we were setting up this test while we were running business as usual, so trying to maintain a normal laboratory service. But then things rapidly started ramping up to the point where we were having to run 300 tests a day, and we had to cordon off part of the laboratory for laboratory staff to work, and we had to dedicate biosafety cabinets for the processing of the samples into the license tubes to load on the machine. We've seen some massive. We've seen some massive fluctuations. I'll point this one out here. This dip was because we essentially ran out of capacity to test. But it has been an extremely challenging time for the laboratory, and the laboratory staff have been amazing. Just to put on the national data as well, so just across the laboratory network, where there's been great collaboration and assistance. So the original labs on board were LabPlus, CSR, CHL, and ourselves. And then there's been a number of other laboratories that have come on board. We've put molecular testing into Nelson, and we have now put, as of a couple of days ago, and today, at different sites, we've now got testing in Queenstown, Queenstown and Clyde, and Invercargill, Timaru, Nelson and Marlborough, and lots of different sites. We've put some rapid testing in to try and help with hospital flows as well. So that you can see that the laboratory labs have been working extremely hard across the country. This is looking at capacity, how we've built the capacity across the country, and we're now in a position where we can theoretically do almost 13,000 tests a day, which is, given the size of the country, is a massive number. That's a group effort across the country. This is, sorry, the headings are too high up, been cut off. But so in blue, we've got the number of tests that we performed today, or performed per day, and in the orange, we've got the number of tests with the supplies that we had on hand. And this is just to make a point. We've had an extremely stressful few months. We have never, the test, the perfusion that we've been running the assay on is an American piece of equipment. Plastic where it comes out of America. There are only 3 labs in Australasia who set up a lab-developed test on it. There are only 3 labs in America who set up a lab-developed test on it. But actually getting stuff right from the start has been on global supply. Nothing that we've ordered has ever turned up. We've always got much restricted levels of, I mean, they provide us with what they can, but it's always been much less than what we would have liked. And often we've been running with sort of 3 to 5 days worth of testing capacity left, hoping that the next shipment is actually going to get on the next aeroplane out of Sydney, having had the last 2 days where the flight's cancelled, and that then it's going to be able to get on the truck and travel down to Dunedin. So the problem, you'll see here that the number of tests on hand briefly down to virtually the number of tests that we performed per day. So that was when we actually the company tried to fly the reagents from Auckland to Dunedin, and reagents that had been delayed for multiple days finally arrived in the country on Saturday, and they couldn't get to Dunedin until Thursday, having had multiple flights cancelled. So we've been working to set other tests up. So we introduced another assay on the Oz Diagnostics platform, but it just can't cope with the volumes that we needed. It can do up to 80 a day. We're doing max. We did about 800 in a day, and we've just actually today we've just validated another 2 assays because these issues are ongoing. They haven't resolved. So we've now got 4 different assays that we can run for SARS coronavirus 2. So we've been raised this issue around needing more generic testing kits. And in fact, we've been working, I've been sitting on the New Zealand University's Diagnostic Development Working Group, and Richard Blakey's been leading, and Joan Stanton's leading a work stream where we're trying to develop our own, it's been termed homebrew assay kit, so that we're looking to see if we can compile all the components in country to do the testing should supply chains dissolve, which I think they're at risk of doing at any stage, given a lot of the stuff we're doing is on large commercial platforms that comes out of either Europe or out of North America, and we've seen the ability of North America to put a cut on anything leaving. So we've also been continuing to work with Miguel's group. So Miguel's group has cultured the virus. So they're down in the PC3 laboratory, which is a little bolt-on on top of the microbiology building. And that's a fantastic resource that we have that's going to enable our responses. So there's Rodri working in the PC3 lab and has PPE. So that's we've got to handle it at higher levels because of growing it to higher amounts. And we've also sequenced some of those. So most of the sequencing has been done by ESR, but we sequenced the first couple of isolates that we got out of the Otago region. And I can't tell you which yellow dots they are in the phylogenetic tree, but they are two of the yellow dots are from our work. So the other thing, the main thing I've been working on, which has started to occupy more of my time, is pushing for a vaccine and pushing for a local vaccine effort. And I think I just want to point out why we need a vaccine. Not only do we especially need a vaccine in New Zealand because we now are surrounded by a sea of SARS coronavirus 2, and we're hopefully eliminated. We'll have to wait and see. But we've got our borders closed, and as soon as we open our borders, we're likely to reintroduce the virus into an immunologically naive population. But overseas, SARS coronavirus 2 vaccine is desperately required. In the last few days, we've seen a couple of good sero surveys that have come out. So this is one from Spain. Apologies, it's in Spanish. But the take-home message was that despite the carnage that it's has wreaked in Spain, the nationwide sero prevalence is still only sitting at about 5%. And we reckon you probably need 60 or 70% seroprevalence for herd immunity. So there's many, and they've been in lockdown and they're coming out of lockdown, there's going to need to be many more waves of infection and a lot more misery before they are able to get out of that. So this was also, this is in today's news. So again, we know Sweden's taken a different approach. They're trying for herd immunity. Unfortunately, it's looking like, again, it's going to be a painful exercise, so they've only got 7.3% of seroprevalence in Stockholm, and they've actually got one of the higher, ever-increasing death rates, so normalised for population there, but compared to their Nordic neighbours who've got into lockdown, they've got a massively elevated mortality rate. And I saw a piece that I haven't actually read, but apparently it's had a massive economic cost on Sweden despite not going into lockdown. So not going into lockdown might not prevent the economic cost. So there are a lot of vaccine candidates in development. This was taken yesterday, so I might not still be up to date. There's 138 candidates, and 15 of them are in human clinical trials. The most advanced candidate is probably the Oxford chimp adeno vector. But there's also Moderna reported on their mRNA, some immunogenicity from their phase 1 trial on the mRNA vaccine earlier this week, although it was not an official report, just in media. So there's a lot of work going into how we can speed up the vaccine delivery pipeline. So normally it takes 15 years or longer to deliver a vaccine. We clearly don't want to wait that long. So normally we've got a linear process for preclinical testing through phase 1, phase 2, phase 3 trials, and then monitoring going forwards. There's an effort to try and compress this, so we're seeing preclinical testing going on at the same time as phase 1 testing, and there's plans to have phase 2 and phase 3 occurring at the same time. And you'll have heard of Operation Warp Speed that the US government is pushing. We're hoping to have a vaccine by the end of the year. Some caution is required, however. Sorry, I might not be able to see the the top of this, but this is so there's some concerns that have been raised from efforts to develop vaccine, particularly for SARS, the original SARS virus, that some vaccine candidates actually enhance disease upon subsequent challenge, and this is just some examples. These are monkeys that were Chinese rhesus macaques that were vaccinated and then challenged. I think I can't see it there because it's underneath the thing, but I think it was 8 weeks later, and they all developed serum neutralizing antibodies. And looking here at those that got this is an MVA vaccine against the SARS versus a mock vaccination. And while we saw a decrease in the amount of RNA in swabs, we actually saw worse disease in those monkeys that have been vaccinated than those that hadn't received the vaccine. And it's just an example of the histopathology here with this sort of intense infiltrate in the lungs compared to the control monkeys that had less severe disease despite being immunologically naive. And there was a suggestion that it might be antibody-mediated enhancement, because there was a correlation between antibody levels and histopathology scores. So some caution is required in our haste to develop a vaccine. And CPI, which is an organisation, the Coalition for Epidemic Preparedness and Innovations that was set up, I think, in 2017, have been leading the charge on vaccine development globally, and they've set up that they're well aware of these issues and are coming up with some consensus considerations that need to be considered before assessing these vaccines before their deployment. Other concerns around vaccines are around access. So this was a blast from the past, so 2009 H1N1 pandemic. So the WHO said that we supported fair access to influenza A vaccine, but that didn't occur. So the Australian government didn't allow CSL to ship vaccine to the US until they had supplied Australia, and there was even greater issues in other developing countries. So there was there was a lot of discussion around there about having negotiated equitable access in these situations, how this could be avoided in the future, and we've seen exactly the same thing this time with so the world leaders and CPI, a central plank is equity of delivery of a vaccine. But the question is whether that will occur in reality. So we've already seen reports that the US president tried to make overtures to a German company, CureVac, who got an mRNA vaccine to see if they could buy them. The company denied it, but whether it's true or not, we're not sure. There is also, this was from the New York Times from a couple of weeks ago, so we know that the Serum Institute of India is one of the largest vaccine manufacturers in the world, and they're now making the Oxford vaccine in preparation for before the clinical trial results are out. And there is actually a number of vaccine manufacturers that are looking to try and bring the manufacture forward before the investing manufacture prior to the results of the trials being known. But even there, the chief executive of the Serum Institute of India has said that any vaccine would have to go to their own countrymen before it goes abroad. And so quoted from that same piece, a researcher from the University of Oxford saying that the political reality is that it would be very, very hard for any government to allow vaccine made in their own country to be exported while there's a major problem at home. We've seen other episodes. We've seen people buying PPE on the runway of Chinese airports. And then this was just in today's ODT. So AstraZeneca has got licensing rights to the Oxford vaccine, and the US has put in a whole pile of money on the basis that they get first 300 million doses. And the UK government, the UK have also said that their local supply, they're going to supply their own country before they supply elsewhere. And then the other issue is actually making the vaccine. So we're going to have unprecedented demand. We're going to need billions and billions of doses of vaccine. And a lot of these technologies, the chimp adenovirus, the mRNA, these are novel technologies. There isn't existing infrastructure. So this is all having to be stepped up around the world. So I think while we might have a vaccine that's come through clinical trials in 12 to 18 months, I think there's whether we actually see it in the clinic in that time frame in New Zealand is doubtful. So we put a piece about this in the New Zealand Medical Journal, and now what we're proposing is that we should be initiating a program to evaluate the best vaccines internationally and seeing what we could manufacture in New Zealand, so that we can supply here early and also be able to supply to others, including Pacific Islands. In parallel, we think we need a vaccine development program, and we need to partner with others who've got vaccine development programs, such as in Australia, and government, partnering also with government and with industry. We need to look at building our capability for vaccine production in New Zealand, and we've identified that there are a couple of existing companies in New Zealand that have the necessary infrastructure and the experience making vaccines that could be repurposed to make a SARS-CoV-2 vaccine, and then we need to think about how we might roll that out. So finally, to finish on some good news, a couple of papers have come out. So this is the first one's on the one on the left, is on a more simple technology, so it's an inactivated SARS-CoV-2. This is from China. This is the Sinovac vaccine, and they showed that it was in the red and blue here. This is the neutralizing antibody titer. So it gave good antibodies, good neutralizing antibodies, and it seemed to protect against infection. So there's a viral RNA copies, placebo in green, and then with increasing doses, increasing dose, you could suppress transcription of the replication of the throat and completely suppressed in the lung. And they saw no evidence of immune enhancement, thankfully. And then there's another pre-publication on the Oxford vaccine. And while it wasn't perhaps so good at suppressing viral replication in the nose, which there's been some comment on, it did seem to protect against pneumonia. Although I would point out with both of these that the challenge was quite soon after the vaccination. There's also two papers that have just come out in Science, just seen today, come out in the last couple of days. One's showed that animals that have been infected are protected against reinfection when they're re-challenged, and also another one with the DNA vaccine also showing it's effective. So I'll stop there and hand over to Jack. Get out of here.
Okay, James, thank you very much. That was absolutely fantastic insight into what happened. So the last speaker for today is Jack Dummer, and I did hear somebody calling him Mr. COVID in the hospital. So Jack, you need to live up to your reputation, I guess. The seventh floor was cordoned off for every normal living human being, so where there was no chance to get in or out of the seventh floor, and I believe you were more in than out. So thank you so much, Jack, for agreeing to talk today, and tell us what happened behind all these barriers.
Okay, so thank you very much for the introduction. Please, everybody, don't call me Mr. COVID or Dr. COVID. Right, so I'm going to talk about preparing a COVID-19 board. My role in the hospital's response was really integrated into a COVID medical team working group. We then worked with the emergency department, with teams from ICU, the community, and rural hospitals to try and develop a coordinated response. And the problem for us was a new infectious disease, poorly understood but with mortality risk. And I've tried to group our issues that we faced into three main ones that I'm going to go through. So we have potential for very large numbers of patients very quickly. We didn't know how to treat them. We didn't know the best way to support their respiratory systems. And we were dealing with an infection that was a risk to staff and to other patients. And what I've done is I've taken the Ministry of Health data that's available on their website and turned it into a GWIS graph. And I've cut off the part where the number of cases per day started tapering, just to show you that my involvement, I was asked to be involved here with a number of colleagues around this time, around the time of first diagnosis in the DHB. We had our first admission very shortly afterwards on the 18th of March. And lockdown really started sort of depending on how you define it, between the 24th and the 26th, I think, of March. But this period, over that 3 to 4 weeks, really it felt like a high stakes, high pressure environment to be working in to try and get our response underway. So in terms of dealing with a large number of patients, you need beds. And so as Michael's already mentioned, Ward 7A was cleared out. Our respiratory patients and our cardiothoracic patients were moved elsewhere. 7A became the COVID-19 ward. Older people's health were moved up to Walkery, and 6A and 6B were cleared and prepared to accept COVID-19 patients as well, giving us a capacity on those 3 wards of around 60-ish beds as an upper limit. As well as that, you need staff, and some of my other colleagues spent a lot of time trying to get rosters developed. Victoria Turner on the 7th floor for nursing. My colleagues Dion Astwood and one of our medical registrars, Rick Kumar, were involved in developing rosters for the medical officers, doctors. That was a lot of effort. It was impressive always to see how many people stepped up to volunteer. The COVID-19 medical team structure is important, and I will dwell on this just for a moment. We decided that what we would do, we would have, so the intention with these additional staff who were available from cancellation of work, so specialists, were brought into internal medicine teams to essentially beef up the internal medicine teams. And from there, that then gave internal medicine capacity to provide doctors into COVID-19 teams along with the respiratory team, so that we could develop teams as our response needed to increase. We would have quite large teams, we still would have large teams. We would have 2 consultants on the team and at least 2 junior doctors, with the intention that means that we have large numbers of people involved from an early stage, so that people get a chance to become educated. It also means that if we need to develop new teams or bring new teams rapidly in, you can divide teams, and so that new people coming in are not unsupported. They can join with more experience. You can split up experienced teams and get them joining with inexperienced staff, so that no one is left isolated in what has been a very challenging environment in a lot of countries to work in. The other thing that it does as well is it gives you some robustness against staff illness as well, because that's been another major feature in hospitals around the world. We also need to provide some sort of support and education, so we've been doing that. Of note here is our guideline. So in Dunedin, we have our Dunedin Hospital COVID-19 guideline. You can see we're up to version 5. Version 1 was banged out about 60 to 90 minutes late on a Friday evening by myself and an ED colleague, and was 5 pages of instructions. That's now increased to about 20-something pages of information that we hope would give enough information to people treating COVID-19 from go to woe, so that they have the advice and support that they need written down, as well as supported people circulating to advise. With larger volumes of patients, you need good patient flow. I won't go into streaming of red and green patients, which is really happens before they hit the ward. Our real problem in this hospital is the cohorting of suspected and confirmed cases. The reason being, clearly, if you've got a confirmed case, you can put confirmed cases with other confirmed cases for the most part. If you have a suspected case, you have to isolate them until you know which direction to take them, whether they are confirmed or whether they're non-COVID patients. That's a challenge in an old hospital with a lack of isolation rooms. We have 4 single rooms on our Ward 7A. It means that we have to take quite a large proportion of the hospital to safely confine suspected cases to individual rooms. And I've mentioned as well here good integration with departments within the hospital and without. I'll talk a little bit about respiratory support. So the majority of patients in the hospital with COVID-19, their major problem is hypoxaemia, so low blood oxygen levels. If you have a large number of patients requiring a high flow of oxygen all at the same time, there's potential for very high demand that can run down your oxygen supply. There are a couple of problems. You can just simply run out of oxygen, which has essentially happened in other hospitals around the world. And if you're driving high flows through the pipes, you can actually freeze the pipes as well and stop oxygen getting through to where it's needed. And again, in the middle of this, you can see that, in fact, that's driven some hospitals to have to adjust the setting the target oxygen saturation, target blood oxygen level for their patients to lower than you would usually wish to achieve, just to share the oxygen around and make sure that there's enough to go around, which really isn't ideal. Modes of delivery. I've written down here about high flow nasal oxygen. We quite like high flow nasal oxygen for most of our patients. Physiologically, it's quite a nice thing to do in patients with pneumonia and significant oxygen requirement. But it's not been around for very long. We don't know about its risk in terms of aerosolizing virus. What you do with this device, you put about 30 to 60 litres of humidified gas, humidified air through the upper airways via the nose, and you can entrain oxygen into that, varying from about a concentration around room air up to about a concentration of 50%. Works really nicely, but we don't know whether it risks virus aerosolization, particularly if it drops off the nose and is at an angle. I'll talk a bit more about that in a moment, but I will come to CPAP. So I suspect most of you have seen on news bulletins these sorts of devices. CPAP is continuous positive airways pressure, and this is what it says on the tin, really. What you do essentially is you either strap a mask, as you can see in the upper picture, strap a mask tightly to someone's face, or you put them in helmet CPAP, as the chap is in the picture below. And you provide respiratory gas at pressures that are slightly higher than room pressures. That has the result, it recruits or prevents de-recruiting of the airways, and in particular the alveoli, the breathing sacs in the lungs, and that helps with oxygenation. So it can be an important and useful part of therapy for these patients. Again, as given standardly with most of the devices that we have, it's an aerosol generating therapy. So that again presents another problem for us. In addition, if we get large volumes of patients, suddenly you need 20 or 40 or 60 of these devices. And if you're trying to get hold of these devices and everyone else in the world is at the same time, it's going to be quite difficult. So it's a challenge to try and overcome to actually be able to provide this treatment. What we've done is in line with what a lot of people have done across the world. Essentially, I won't call it improvisation. It's not improvisation. It works, and it works well. But essentially, we're using home CPAP devices at the moment. And these home CPAP devices, if you look at the mask here, this is a routine mask that we use for people using home CPAP for sleep apnea. And at the top of the mask, it has these three little holes. And aerosol forms where you have, one of the ways aerosol forms is if you have droplets of a substance and you bring it into contact with fast-moving air under pressure, you can blast it and create an aerosol of particles of, for the sake of argument, maybe 5 micrometers and smaller in diameter. And so these things are very good for doing that. So instead, you have to get a new circuit. So you have to source a different kit. This is a mask. So this is the kit that we have. So you can see we have a mask. This does not have those little dots, little holes at the top. And in between the tubing and the mask, we now have an exhalation port. We can breathe out through this port. And we have a filter. So you breathe in, just as you would normally, and then you breathe out. You breathe out past the filter, so the gas that you breathe out is filtered, and then out via the exhalation port, and you can supply oxygen via this little port here. This then attaches to a home CPAP device. Again, these are not perfect, but they will do if you have nothing else. And they don't, for example, have a battery pack as backup if you have a power cut, which could potentially be an issue. They do not have an oxygen sensor on them either. So we have to have our own oxygen sensors to check and check what the oxygen concentration is in this setup. But you can achieve oxygen concentrations where you want to be, which is around 50% and over with this setup. I'll talk a little bit about staff safety. I think a lot of people are familiar with personal protective equipment and issues around supply in the media. We have a supply, we've been trained, so we've gone through a training process, so everyone's reasonably comfortable now wearing the equipment. The ward facilities on 7A are really quite radically different compared to what they look like on other wards. When you walk in, you go straight into a little room, side room, where you walk in the clean area, change your clothing, get into scrubs, come back out, put your boots on, and head off to the ward. And when you come back and you leave your shift, you go into the dirty area. You can go and get rid of your scrubs, have a shower, and then come out the clean side, get rid of your boots, and out you come. You can see everything on the ward, everything that's carpeted is covered in this revolting adhesive plastic, so that it's white clean. The other issue that we face is ventilation on the ward. So we work, as you again are all very aware, in an old hospital. We do not have proper negative pressure environments anywhere, basically, in this hospital. We have two on our 7A ward that have exchanges of air around every 4 to 5 exchanges per hour. What you need for modern standards is 12 or above. What we've done is we've recruited sort of ventilation engineers to fit these devices into some of our rooms. This is basically a pumping air out through the window, or the window, via a HEPA filter. So air is pumped out at around 16 to 18 exchanges per hour through the vent and out of what was once the window and is now just full of metal sheeting. They're quite loud, about 60 decibels. If you're on an airliner, it's about 70 or 80, so it's quite annoying. It's more than a low hum, but at least it's a constant sound that you can kind of get used to over time. So that's another challenge we've faced. So that's a brief overview of some of the major issues that we face, and there are plenty others. And we're on an ongoing process of preparation. Clearly, like James and like Susan, we have to keep on working, keep on maintaining knowledge and expertise on treatment in particular, so therapies, update the guidelines on a regular basis. So version 5 will be out, I hope, in the next few days of that guideline. And the guideline, so I should mention to any DHB staff listening, is available via the microguide app as well. So if you've got the microguide, you can get the COVID guide on that as well. We're involved in clinical trials with having patients. We're lucky in that regard, in one sense, that we don't have any patients, but we are all teed up to be involved in any clinical trials across Australia and New Zealand for therapies for patients. Integration of our response with other teams around the DHB continues, as does a nationwide response. Again, we're connected to networks of colleagues around the country, exchanging ideas and working through issues together. And lastly, at the moment, the COVID-19 ward the intention is to move that from the 7th to the 6th floor in coming weeks. So we're busy preparing for that at the moment, and this is just the blessing of that ward prior to its opening. And my last slide is just, there's been quite a lot of interest in the community about what's been going on in the hospital. This is a doctor and a filmmaker, Paul Trotman, and his colleague has been making film of COVID-19 preparations around the hospital. And this is one of the stills from when they went around, they took photos as well. And unbelievably, I mean, this looks like it should be a still from the advert for a drama from Netflix, for some kind of medical drama, but in fact it's believe it or not, it's one of our 4 bedders that they've set up to sort of quite dramatic there as well. And I'll leave it there anyway, so if Michael wants to direct or chair any questions.
Good. Thank you so much, Jack. Gosh, there's a lot of preparation must have gone into that as we became aware of the 3 talks here. And I think we still can say that we're in the very lucky position that it seems like COVID went past New Zealand and probably past the Dunedin Public Hospital. But of course, we had to be prepared for that. It's on the dot 2 o'clock, so I wouldn't mind if people have to leave and go back to work. But there are, all the three speakers are still online, so if there are any questions, please fire away with them right now, please.
James, I wonder, when we open up the borders, the significant numbers of people coming in, obviously there's going to be questionnaires and temperature checking. There's been a lot in the media about more rapid tests, so that you could know the people coming back who is safe to go and who's going to quarantine. So at the moment, everybody was getting quarantined with those small numbers, but when you get bigger numbers, that's probably not going to be feasible. How are those sort of tests? Can you use your lab's test for that, or there's these other ones overseas which are said to be variable?
Yeah, so the gene expert, essentially you have to test by nucleic acid amplification. So it's PCR. The quickest, there are some that do it in half an hour. There's the Abbott one. We're not going to get that in New Zealand because you're not going to get it outside the US. I think they're using them all in the White House. We've got the gene experts. You could theoretically run those. They take about an hour. The issue is going to be around the incubation period. And we know that, yes, you could test someone who's asymptomatic today and they'll be fine today, but they might still be incubating for another 14 days if they were exposed on the aeroplane. And then they're going to become infectious later. So I think what's going to happen to the borders is a very interesting discussion. I mean, it's clearly a huge economic cost to the country having them shut. We've also invested a huge amount of money in trying to get rid of SARS-CoV-2. Personally, I'm struggling to see how we can open them until we've got a vaccine, but maybe in a limited way to Australia, if Australia manages to essentially eliminate as well. The Ministry may have other ideas. Susan might have some comments on that, but that's from an outside perspective. I'm struggling to see how you could have border mechanisms that would prevent introduction. We're going to have to continue having massive surveillance in the community. I mean, especially if we do open the borders. To any degree, we're going to have massive community surveillance.
Yeah, just on that note, I mean, if we look at 1918, the second wave was worse than the first wave, and then H1N1 went into seasonal flu. So some of these things, is there any concern that SARS-CoV-2 will be a seasonal thing? So we almost kind of have to be, prepared. And then also with the vaccine rates, I was reading something in the US that actually large portions of the US population don't want vaccines. So it's very hard to get 100% vaccination rate. I mean, even if we do 67, that's a remarkable achievement. I'm just wondering, almost going to have to be at that state of really preparedness, and how do you see this playing out long term?
I mean, I think this virus is with us forever.
Yeah.
Now, I mean, it's there's no way we're going to eliminate it globally, and I think it will. There was a modelling paper that came out a week ago or something that suggested it could become seasonal. But there was also a suggestion in that paper, I believe, that it's unlikely to be seasonal this year because there's too many susceptible people. So I don't think it's going away. I think it will be with us, and it probably will be one of the seasonal viruses. And whether we need a one-off shot of thing or whether we need an ongoing, it seems that it does mutate more slowly than influenza. It does have a proofreading function. It's got an RNA polymerase. So it may be that you don't need to update the vaccine often. Or maybe we need boosters to keep the level of immunity up. I guess we have to wait and see how that plays out. I don't know.
Excellent, thank you. I see Kirsten there, just to take somebody from the Zoom panel. Kirsten.
I think the question's for you, James. I'm just wondering what the latest is around false negative tests, and what proportion would you expect that you might be seeing in New Zealand versus other laboratories?
Yeah, I think the data is really murky around performance. I mean, I think a lot of those early papers that came out that said it was only 70%, they were testing people who were quite late in the illness and that they were in hospital with pneumonia. And it's not always clear what the gold standard was. Sometimes they use CT as a gold standard. I'm not convinced that CT can discriminate different causes, viral causes of pneumonia. I'm glad that Jack agrees with me. So I think we've got a bit of a wide estimate at the moment, but I think based on our other experience, I think it depends on when you spot people. We know that most of the shedding is early on, and then in the upper respiratory tract, and it drops, and then later on, the lower respiratory tract is certainly probably a more sensitive sample. I think if you're sampling people early, I think the sensitivity is very high, and it's probably much more like 90–95% than the numbers that are bandied about. So I don't think we have. I guess it's all muddied by the lockdown, but I think the way that it's come under control would suggest that we haven't missed a lot of cases.
Good, thank you very much. Now, I personally have to leave that discussion. Is Kim or Luke still in the seminar room?
Yeah, I'm still here. Yep.
Kim, if you want to carry on with that discussion, that would be fantastic. I could imagine that many more people have much more to say. So once again, I'd like to thank all the contributors to the session. It was a fantastic kickstart to our seminar series. I counted about 50-odd Zoom participants, and assuming that at least 20 people were behind each camera, we had hundreds of people listening into that seminar. So that's absolutely fantastic. I would also like to point out our next seminar, which is in a couple of weeks' time. So you all know we have Professor Subramanian as our new dean, and he was appointed with a new vision of for the Otago Medical School, and he has agreed to speak at our next department seminar on that vision and in what form it will affect the Department of Medicine. So I would urge you all who are interested in the future of our department to participate in that seminar to discuss the future of this department. And then obviously very important is Takiwa is also participating. Takiwa is our liaison person, so to speak, for lack of a better expression. And she has been employed in the Department of Medicine to help us embrace other ethnicities, and especially Maori research into this department. So she will also have an overview of what her role could be in the department and how we can make best use of her role. And I'll hand back over to Kim for some further discussion. Thank you very much for tuning in today. Thank you.
Great. Does anyone else have any other questions?
With all these vaccines that are being developed and gradually being sifted through, are there any discussions about people getting together and making comparisons of vaccines, or is it still very much?
There is talk of running, of amending trial design and having head-to-head in much the same way as they do with some of the antiviral treatments as well. So there is, it's just, I guess, a question of when they get to the efficacy stage, and I think it's also going to be challenging how you run efficacy studies or where you run efficacy studies. In the UK at the moment, they're sort of running a phase 1/2 with the itch and bed, and you've got a lockdown. And, in some ways, it kind of you don't want things coming under control just while you looking to see if your vaccine's efficacious. Otherwise, you're probably going to need rather large groups anyway.
Yeah, it's getting to be a big exercise to try to achieve the information. Yeah, so if you're starting to pay now, that's good. Yeah.
Any other questions? Yep.
Sorry.
Yep, sorry.
James, it's probably too early yet, but are there any reliable cases of people who got better and got reinfected, or are those people who've had a recurrence of symptoms? Is it's just that they completely got rid of it and they've still got, it's still just a one-off phase?
Yeah, I've seen no good evidence. I've seen no good evidence of reinfection. And you see people who become intermittently positive as they're clearing it. People can remain shedding for sort of 50 or 60 days, they can remain PCR positive, and I mean, you can get an intercurrent illness or something else during that time, or you get some post-viral symptoms. Yeah, so I mean, I don't think there's as yet any good evidence to suggest that people can get reinfected. I don't know if, Jack, if you've seen anything.
No, we haven't. We've seen, and I've had discussions with Susan actually about 1 or 2 patients with ongoing symptoms, as you described in your talk, Susan, but nothing clearly that represents reinfection.
I have a question. There's been a lot of talk in the media about kids and whether or not they are, not as good at transmitting it, or if they just don't get symptoms, or how contagious they are. Do you guys have any thoughts on that?
They seem to get infected at a similar rate, would be what some of the recent data is suggesting, but they seem to mainly, I mean, Susan can correct me if I'm wrong here, but my impression from the literature is that they tend to be the ones that they get infected by other household members rather than being the ones who've got play a massive role in transmitting to others. So Susan's come online.
I think it's just as James has said, children seem to have a much milder course of infection if they are infected, or they may be asymptomatic. There was a couple of papers that came out in the last couple of days suggesting that the ACE2 receptor might be lower in children, but I don't know. If James, you might have an opinion on that. But look, I'm also sorry, I'm going to have to go on to my next meeting. So thanks very much, everybody.
Thank you, Susan.
Yeah, sorry, I have to go as well. Yeah.
Okay, no worries.
15 minutes left.
Well, should we? I think we should probably knock it off there. Thanks everyone for attending. See you next week or a couple weeks. Thank you very much.